Assalamu alaikum, I'm Amira Nasrallah and I will talk about rheumatic heart disease and infective endocarditis. First, I will start with basic anatomy of the valves and basic diseases that can help us know the rheumatic heart disease and infective endocarditis better. So the heart have four valves, two AV valve or atrioventricular valves, which are the tricuspid valve, which have three leaflets, and the bicuspid valve, which have two leaflets and is also called mitral valve. And we have two semilunar valves, which are the pulmonary valve and the aortic valve. First, starting with the aortoventricular valves. So, as I said before, they have leaflets, and these leaflets are supported by subvalvular apparatus, including the chorda tendineae that attach the leaflet to the papillary muscle, and this papillary muscle originates from the myocardium, and when the myocardium contracts during systole, the papillary muscle also will contract, and this will tighten the chorda tendineae and will prevent the prolapse of these leaflets to the atria, thus preventing the backflow of the blood into the atrium during systole. So the semilunar valves, which are the pulmonary valve and the aortic valve, has three cusps that make a three pocket-like dilatation, which are called sinuses. And these are the pulmonary sinuses and these are the aortic sinuses. In the aortic sinuses, we have the origination of the right and the left coronary arteries. And then starting with the first important disease, which is strep throat, that is caused by strep pyogen group A beta hemolytica disease. So as you see here, we have the strep pyogen, which is a group A beta hemolytica, and this strep pyogen will secrete enzyme called streptolysin, which will go and cause complete hemolysis of the RBC. And it's important to know that strep pyogen secretes streptolysin because you can screen for it by ordering ASO titer or anti-streptolysin O titer. And the strep throat is diagnosed by the central criteria. I put it here if you want to read it. And if the patient was found to have strep throat, you need to treat it to prevent the complications that we will talk about. So untreated strep throat will cause a formation of antibodies by the immune system to a highly antigenic protein found in the strep pyogen, which is M protein. This M protein have similar structure to proteins found in some tissues in our body, like the heart, joints, and skin. So the antibodies will not only attack the M protein, also it will attack the tissues that have similar proteins, and this is called molecular mimicry. So, as I said before, strep throat, untreated, it will cause autoantibodies attacking our own tissue, and if it attacks the joint, it will cause post-strep reactive arthritis. If it attacks the brain, it can cause BANDAS or pediatric autoimmune neuropsychiatric disorders associated with strep infection. And if it attacks the glomerulus only, it can cause post-strep glomerulonephritis. And if it attacks multiple tissues that fulfill the Jones criteria, then it will cause, or it is called a rheumatic fever, and a recurrent rheumatic fever that damages the heart valve can cause chronic rheumatic heart disease. So acute rheumatic fever is basically diagnosed by the Jones criteria that in which you need to have a throat culture that is growing group A beta hemolytica strep or elevated ASO titer that we talked about before, plus two of the major criteria or one of the major criteria and two of the minor criteria. The major criteria, you can memorize the criteria by Jones Cafe-Ball. Major criteria including Jones, so joint involvement, O for heart, carditis because it looks like a heart, N for nodules, subcutaneous nodules, E for erythema marginatum, and S for Sydenham corium. For the minor criteria, it includes elevated CRB, arthralgia, fever, elevated ESR, prolonged PR interval, and anamnesis of rheumatism, and lastly leukocytosis. And the most important risk factor of acute rheumatic fever is a child living in a crowded and poor area. And the first line treatment of rheumatic fever is penicillin if the patient have an active infection. and rest, and you can give him some anti-inflammatory drugs. So these are the signs the patient will have that are included in the Jones criteria. The first one, which is the subcutaneous nodules. So it's basically caused by a collagen accumulation here in lump. And then we have the erythema marginatum, which is usually painless and non-paralytic, and usually it's found in the trunk and limb, and it spares the face. And then we have the Sydenham-Curia, which is caused by the antibodies attacking the basal ganglia, causing rapid involuntary movement in the face and arm, and this usually happens later in the disease. And finally, we have the migratory polyarthritis, which is the joint involvement, causing multiple large joint inflammation that travel from one joint to another, and this joint inflammation will not cause a permanent damage. Then going to the carditis, so rheumatic fever can cause pancarditis, which means inflammation of the all heart layers, which are the pericardium, myocardium, and endocardium. So it can cause pancarditis, or it can cause isolated inflammation of the heart layers. So starting with the rheumatic pericarditis. So the inflammation will cause the increase of the permeability, allowing the fibrin to enter the pericardial space and aggregate there. And if you look at it, it will look like a butter and bread in appearance. And the patient will complain of sharp chest pain that is relieved by leaning forward. And when you auscultate the patient chest, you will hear a friction rub. Then, if the myocardium was involved in rheumatic fever, it will cause rheumatic myocarditis, and this is the most common cause of death in patients with rheumatic fever. So the inflamed myocardium will be tired and will not and cannot pump the blood adequately, so the blood will accumulate here, causing the cardiac dilatation and dilated cardiomyopathy, and this will result in mitral insufficiency and congestive heart failure. Lastly, it can cause rheumatic endocarditis. So the immune complex will come and attack the endocardium, causes erosion, especially at the endocardial lining of the valves, and it will cause regurgitation of the valves, and usually it affects the high pressure valves like the aortic and mitral valves. And the most common affected valve is the mitral valve, causing mitral valve regurgitation. Then this eroded place will cause the exposure of the underlying collagen and platelet factor to the blood, and this will attract the platelets and fibrin to come and attach here, causing build-up of small thrombosis or sterile vegetation, and in this case we call it a non-infective endocarditis. So if you take a biopsy from any layer of the heart, you will see something called Ashef body, and inside it you will see a Nitschko cell. So Ashef body basically is an area of fibrinoid necrosis that contain immune cells, and if you take one of them, which is the Nitschko cell, you will see it like that. So a Nitschko cell is basically a modified macrophage with a nucleus that looks like a caterpillar, and it's the Ashef body is characteristic of rheumatic fever. So this is just a short story in order to memorize some important information in rheumatic fever. So Ash, who is a child, who is sick, and he have sickness in all his body. So Ashef body, and because he's a child, so risk factor for rheumatic fever. And why he's sick? Because he was attacked by a caterpillar that caused the development of the Nitschko cell. So Dr. Jones came and gave him penicillin to get better. So penicillin is the treatment if the patient have an active infection in rheumatic fever. And Dr. Jones, which is the Jones criteria. So if the patient had a repeated attack of rheumatic fever, this will cause fibrosis and scar formation in the valve leaflet and chorda tympani, and this will cause the fusion of the commissure, and this will cause a permanent damage to the heart valve and causing a disease called chronic rheumatic heart disease. So because of this scar formation and the fusion, the patient first will develop stenosis, and this is the most commonly valve abnormality that they will develop, which is narrowing of the opening of the valve, and later they can develop regurgitation. So as you see here, this is a fusion of the commissure in the mitral valve, and if you look at it, it will look like a fish mouth or a button hole in appearance. And usually the most common frequent cause of mitral stenosis is chronic rheumatic heart disease. So if you were asked what is the most common cause of mitral stenosis, you will say chronic rheumatic heart disease. On the other hand, we have stenosis of the aortic valve, in which you have calcific nodules that causes the opening of the valve to be narrowed into a triangular opening. And rheumatic heart disease is not a really common cause of aortic stenosis. We have other common causes of aortic stenosis, which are senile calcific aortic stenosis in patient more than 70-year-old, and in patient less than 70-year-old, most common cause of aortic stenosis is congenital bicuspid aortic valve stenosis. So basically, chronic rheumatic heart disease can be prevented by giving prophylaxis antibiotic penicillin for patient with repeated infection with group A beta hemolyticus streptococcus. Endocarditis, which is basically the inflammation of the endocardium, can be of two types: infective endocarditis and non-infective endocarditis. Infective endocarditis, which include acute, subacute, or prosthetic valve endocarditis, and non-infective, which include rheumatic heart disease, endocarditis, Liebman-Sack endocarditis, and non-bacterial thrombotic endocarditis. So for the pathogenesis of endocarditis, so the patient will have risk factor like high blood turbulence or congenital or acquired heart diseases, or immune complex mediated damage, as we said before, that will causes endometrial inflammation and damage, and this will expose the underlying collagen and tissue factor to the blood, and this causes the aggregation of platelet and fibrin, making a sterile vegetation, and this thrombosis or blood clot is called non-bacterial thrombotic endocarditis, and usually it happens in patients with hypercoagulable state, in hyperestrogenic state, and in some malignancies. And if this thrombosis happens in a patient with SLE, we call it Liebman-Sack endocarditis, and if it happens in rheumatic heart disease, we call it rheumatic heart disease endocarditis. So if the patient had bacteria in the blood coming from anywhere, like from the gums, gut, lungs, IV lines, catheter, and so on, this bacteria will come and attach to this vegetation and causes colonization and causes a non-sterile vegetation. And this vegetation, the sterile and non-sterile one, can dislodge and embolize easily and causes embolization signs and symptoms like stroke, MI, and so on. And embolization is very common in infective endocarditis and in non-bacterial thrombotic endocarditis. So infective endocarditis has three types, as we said before, starting with the acute infective endocarditis, which is caused by a high virulence organism. That means the organism is highly destructive, like Staphylococcus aureus. Because it's highly destructive, it will affect both the healthy and the damaged heart, and it will have a very rapid onset disease, and the patient will have severe constitutional symptoms, and the patient will have a high mortality rate, and usually he does not respond to the treatment, and he needs very aggressive antibiotic treatment. For the subacute infective endocarditis, it's caused by a low virulence disease. That means it's less destructive bacteria like Strep viridans, and it have a gradual onset, and because it's less virulent, so it will affect only the already damaged valves, and the patient will respond to treatment easily. So example of damaged or abnormal valves are chronic rheumatic heart disease, mitral valve prolapse, bicuspid aortic valve, and calcific valvular stenosis. And the risk factor for infective endocarditis overall are diseases that decrease the immunity, like neutropenia, immunodeficiencies, malignancy, immunosuppression therapy, diabetes, and IV drug abuser. The last type of infective endocarditis, which is prosthetic valve infective endocarditis, that happen after prosthetic valve surgery, It can be an early onset that happen within 60 days after the surgery, and the most common cause is Staph aureus, and also it can be caused by Staph epidermis. The late onset prosthetic valve happens usually at the 60th day of surgery or after it, and the most common cause also is Staph aureus. However, it can be caused by streptococci infection. So these are some important notes. So the most common cause of infective endocarditis in IV drug abuser is Staph. However, it can be caused by Staph epidermis. The most common site for infective endocarditis in IV drug abuser is mitral valve. However, IV drug abuser can have infective endocarditis in the tricuspid valve. And the most common cause of infective endocarditis in prosthetic valve surgery is also Staph aureus. So in summary, the most common cause of infective endocarditis overall is Staph aureus. These are some other important notes. So a patient with infective endocarditis due to strep bovis, you need to screen for colorectal cancer. A patient with endocarditis, but he has a negative blood culture, you need to think about other organisms that are not that will not appear positive in the normal blood culture, like the Hague organism or fungal infection. And this is an important slide to differentiate between the vegetation of each of the endocarditis type. So starting with the infective endocarditis, as you see here, it have a large, irregular, destructive vegetation. As you see here, it's destructing the leaflet and the chorda tendineae. Then going to the non-infective endocarditis, starting with the rheumatic heart disease endocarditis. So you see here we have a small vegetations that are in the junction between the leaflet and the chorda tendineae, or you can say that is in the line of the closure of the valve. And also the non-bacterial thrombotic endocarditis is also at the line of the valve closure. And as you can see, it's bigger than the rheumatic heart disease vegetation, and it can be one or many vegetation. Finally, ending with the Liebman-Sack endocarditis. Liebman-Sack endocarditis. So it have a variable sized vegetation, and most importantly, the vegetation are found on both sides of the valve, and this is characteristic for Liebman-Sack endocarditis. So ending with the endocarditis sign and symptoms and criteria for diagnosis. So to memorize the sign and symptoms, you can memorize from Jane, which include fever, rough spots, Osler node, murmur, Janeway lesion, and anemia of chronic disease, nail hemorrhage or splinter hemorrhage, or finally emboli. So the murmur usually is caused by valvular regurgitation, mostly mitral valve regurgitation. Then going to the criteria to diagnose infective endocarditis. So the patient should have positive 2 major criteria, or 1 major criteria and 3 minor criteria, or he should have all the 5 minor criteria. So the Duke major criteria include B, so blood culture that are positive 2 times, that are 12 hours apart, and E for endocardial involvement that are characteristic for endocarditis seen in the echo. And then for the minor criteria, that is abbreviated by fever, F for fever, E echo finding that does not fulfill the major criteria, V for vascular finding, E for evidence of microbial or immunological problems, and R for risk factors like drug abuse, valvular disease, and so on. So finally, I will just explain some of the findings in endocarditis, which are important to know. So in an infective or bacterial vegetation, so the bacterial vegetation that are found in the cardiac valve can dislodge and embolize, causing aseptic microembolization that can go to the nail blood vessels, causing splinter hemorrhage, or it can go to the palms and soles, causing erythematous macules that are painless, causing this lesion, which are called Janeway lesion, and it's important to know it is painless. And on the other hand, if the immune complex get deposited in the pads of the fingers and toes, it will cause something called Osler node. So from node, it will cause nodules and a painful nodules. So Osler node, and for nodules, and O for ouch, which is painful. And finally, broad spots will be caused by immunocomplex deposition in the retina, causing retinal hemorrhage with a pale center. And if the immune complex was deposited in the kidney, it can cause acute kidney injury or glomerulonephritis, which can present with hematuria, anuria, and proteinuria. This is the end of the lecture. These are my references, and thank you very much.